All right, every year, more than 2 million children are hospitalized, and the most common reasons are usually related to problems with the lungs or respiratory causes. So the most common diagnoses are shown here, but acute bronchiolitis, pneumonia, asthma, just to name a few. So when parents are there, they're kind of thrust into this unfamiliar environment with a lot of things happening to their kids. And my plan today is to demystify some of those interventions and talk about how is the medical team planning to support the lungs. My name is Brandon. I'm a board certified pediatrician and pediatric ICU doc, and I'm looking forward to talking to you about it today. So super quick review, the lungs, in my opinion, basically have two main jobs. One is get oxygen in, and two, get carbon dioxide out. So oxygen is critical because it really helps cells do all of the vital functions they need to do to maintain life. Carbon dioxide gets produced as a waste product, and so we basically have to get rid of it by breathing it out. So how do we know if the lungs are getting enough oxygen in or carbon dioxide out? Well, the oxygen level is actually pretty easy to get. So there's a machine called a pulse oximeter with a little probe that goes on the finger, the toes, or the wrist, the foot for small infants, and it just tells you how much oxygen is in the blood. The number can go from 0% to 100%, so fully saturated, and anything over 90% is what we shoot for, but super normal would really be somewhere above 95%. Most of us walking around, if we don't have COPD or some other lung disease, it's gonna be above 97%. So I'll just point out, if your child does get hospitalized or they're in the ER and they get put on the monitor, you can see it here, but it's usually this light blue number. And one thing I just wanna point out is these things over here. So we call them waveforms, but it's just really critical that these numbers are only accurate if these waveforms look something like this, where they're very regular, normal, and just look like a good pulsation. That's basically what they're picking up. The only reason I say it is a lot of parents will get glued to the monitor, which is very reasonable. I would be too. But if this waveform is really erratic, like the baby's moving or crying or agitated, then oftentimes you won't get a perfect signal, and so the oxygen level will read very low, but it's really just inaccurate. Okay, so pretty easy to tell oxygen. Carbon dioxide's a little bit harder. There are some sensors that can use the skin, you can use some nasal cannulas, and if a breathing tube is placed, you can get a good idea what the carbon dioxide level is. But in general, if you really want to know, you have to do what's called a blood gas. So this is a lab sample that in babies you can get from a finger stick or a heel stick, but for most other children, you get from the vein or the artery, and actually have to look at a lab value. Okay, so I think that's pretty much all we need to review. Now let's talk about how do medical teams think about supporting babies or children who are having trouble breathing. And this graph is really helpful to me. So on the y-axis, it's really how severe is the child's lung disease, or how much trouble are they having breathing. And then on the x-axis, it's how much time has passed. And so you can see it kind of has this like big hump to it, where what normally happens is the amount of support that's needed goes up over time as the illness gets worse, and then it comes down over time as the illness gets better. And this has perfectly listed the common ways that we support the lungs. So we start with just a little bit of oxygen, then we go to something called high flow nasal cannula, then CPAP or BiPAP, and then if none of those things are helping, we often have to put in a breathing tube and do what's called mechanical ventilation. Okay, so let's start off with a case, and we'll say it's a child with bronchiolitis. And we said in the other videos that RSV bronchiolitis tends to get worse around day 5 to 7. So let's say a child comes into the emergency department and it's day 1 or 2 of illness, and they actually look pretty good. You know, they're working to breathe a little bit, but not too bad. They're moving good air when you listen to them. But when you put that pulse oximeter on, you see that their oxygen saturation level is 86%. And you say, okay, well, this is actually too low for us to monitor safely at home, and we should probably correct it, because again, we're shooting for more than 90% in the blood. Well, that's where this device, it's called low flow nasal cannula, comes in handy. So to understand how this works, we just have to do a quick timeout about the air we're breathing. So the specifics don't matter, but when we're breathing regular atmospheric air, or in medicine we call it room air, it's 78% made up by nitrogen particles, and most importantly, 21% of it is oxygen particles. So 21% of all the air we're breathing is oxygen. Okay, so why is that relevant? Well, basically, when we take this low flow nasal cannula, all we do is we put it in the baby's nose right here, and it is going to be putting out 100% oxygen. So all the air we're breathing is 21%. This has 100% off the wall. So you can imagine, baby takes a breath. Some of the air that's coming in is from the room, has 21%, but some of that air is from this cannula, which is giving 100%. And so you can imagine that it'll make that number go up. So it was 86 before, maybe now it goes up to 95, 96%, even with just a low rate of flow. And that's why it's called low flow oxygen. A couple things to note, it is annoying to babies and children at first, but honestly, they get used to it pretty quickly. It's pretty low profile, and so you can usually eat and drink as long as the respiratory distress isn't too bad. And then the last thing I'll say about it is that the air itself, it's not heated or humidified, so it can be drying to the nose, and sometimes the prongs themselves cause irritation. So if you do have that issue, then you can just put a little bit of Vaseline or Aquaphor, and that usually helps. So let's say, we're sticking with the patient and it's now day 3 or 4, so we're getting up towards that illness getting a little bit worse when we expect it to peak day 5 and 7, and we see some work of breathing. So it's not just that the oxygen level is low, but now, there's a little bit of respiratory distress. So something we can try to do for our next step in management is what's called high flow nasal cannula. It looks very similar to the low flow, but it has a little bit bigger prongs that are wider and can tolerate more flow. So again, this kind of just goes in the baby's nose and sits there. And this one is nice because we don't have to just give 100% oxygen. We can actually turn the dial and decide how much oxygen we want to give. We can also turn the dial and change how much flow we want to give or how much support we're giving to the baby. The flow rates vary by size. Little newborn infants will sometimes get around 5 to 8 liters. And then the bigger you get, really big kids or people my size would be like getting 50 to 60 liters per minute flow. And so here, there's really multiple benefits. So you can give more oxygen, but you can also wash out a little bit of that carbon dioxide. So it actually helps to clear the airways out of the carbon dioxide. So it helps a little bit with what we call ventilation. Moreover, the low flow really just makes that oxygen number come up, but this one can actually help with work of breathing a little bit. And then to close out, I'll say this one's a little bit bulkier than the low flow nasal cannula, but it's not too bad. And similarly, most babies and children get adjusted to it over time. There's some hospitals where you can do this on the floor, but some other places they may want to be monitored in the intensive care unit. And then if the child doesn't have significant respiratory distress, there are times when it's fine to let them eat or drink. But I'll say we're getting more and more support, and as it starts to get worse or the respiratory distress gets a little bit worse, sometimes teams will say that we really shouldn't be eating or drinking by mouth. The same tip as before goes, so if you're getting irritation or bleeding, a little bit of Aquaphor and Vaseline can be very helpful. So sometimes, even on the high flow nasal cannula, we're having to give a high concentration of oxygen, we're still having a lot of work of breathing, or the baby just doesn't seem well captured, they're still having distress and problems. Well, then we can bring in what we call CPAP or BiPAP. So this is a little bit different. So this actually makes a seal either over the nose or the nose and the mouth, and it looks a lot scarier, but it can be much more effective at improving the work of breathing. So how does it work? Well, basically, you can just imagine that when the lungs are sick, whether it's a virus or a pneumonia or there's fluid, you can just imagine there's a bunch of gunk in the lungs and they kind of get collapsed down. What we want to do is open those lungs up as much as possible because that lets more oxygen in and carbon dioxide out. So what the mask does is literally it makes a seal and then transmits that pressure to open the lungs up. So first it opens the lungs, and then second, you can imagine that the children are working to breathe. They're using a lot of pressure to pull air in and get it out. Well, similarly here, they don't have to work as hard if we're kind of giving them a little push by putting that pressure in through the CPAP or BiPAP mask. So for little babies under 3 months, we often just use CPAP. It can be very hard to get BiPAP to work, but for older children, BiPAP is one of our kind of more or most advanced, we say, non-invasive therapies, things before we put a breathing tube in that we can use to help support their breathing. With CPAP, you just have a constant pressure whether the baby or child is breathing in or out. But with BiPAP, every time they take a breath, we actually hope that the machine will give more pressure to help even more air come in and then less pressure as they're breathing out. A couple notes on this. Similar here, we can adjust the amount of oxygen we're giving and adjust the amount of pressure. So those are two metrics of how much support is the child needing. So I will say, the low flow and high flow nasal cannula, usually pretty well tolerated. These can be pretty annoying, especially with BiPAP, and it can cause a good amount of agitation in infants and children. So depending on the situation, some providers may use a calming medicine to help them tolerate it, but not all. But I will say all patients who need CPAP or BiPAP really need to be in the intensive care unit setting. At this point, it's pretty unlikely that the child would be allowed to eat anything by mouth, and there's two reasons for this. One, you can imagine there's a bunch of pressure trying to get into your lungs. Well, if you're trying to swallow food or formula or milk at the same time, there's just a high risk that that food is going to get pushed into your lungs and you're going to aspirate or choke. The second concern is that if a child gets worse, we're moving towards what you would call intubation and mechanical ventilation, where you actually have to put a breathing tube in the throat to breathe for the child. When we go to put that breathing tube in, it's much more dangerous if they have a full belly, and so sometimes we'll say, hey, they just shouldn't be eating just because of concerns of what's going to happen if they get worse. And then the last just little tip, so if there's a child who's just on the nasal mask or a baby, if you see on the screen, the mouth is open. So the nose and the mouth are actually connected here in the back. And if the mouth is open, but the pressure is all here, you can imagine all that pressure and air is just kind of flowing out of the mouth. So it's not really what we would want in an ideal situation. Something you can do is honestly just put a pacifier in, and that helps a great deal. It's hard to do sometimes with the competition for space here, but you can actually cut the top off the pacifier to give a little bit of space so that mask can sit there and still have enough room for the passy so that it works more effectively. Okay, so through all this, our goal was really to avoid what we say, avoid the breathing tube, avoid this thing right here. But if we get onto high pressures on CPAP or high pressures on BiPAP, and we really still just can't support the baby's lungs or the child's lungs, then we often will move to what we call intubation, which just means putting a breathing tube into the throat, and mechanical ventilation, where we actually use a breathing machine to open up the lungs and inflate the lungs or breathe for the child. I can talk about this in a separate video, but just know, again, this is not a death sentence. So if most previously healthy children, whether they're getting intubated for pneumonia, bronchiolitis, or whatever, they usually just get intubated for a couple days and then recover and get extubated. But there are a number of things that go along with it where we have to use sedating medicines. There are risks for other infections that they can acquire when they have this breathing tube in their throat. And so there are good reasons to try to avoid this, but just know that this is something we do very commonly in the pediatric intensive care unit. And so it's not the end of the world and something that we do frequently. Okay, so I think that's about all I have to say. I hope it's clear, with those last comments. I'm not trying to minimize the psychological stress that, parents are under seeing their children go through this. It's something that we see routinely as pediatricians, but it's awful. And I'm sorry every time that we have a family or child who's admitted, especially to the intensive care unit. But I hope that some of this was helpful, at least give an idea of how people think about this respiratory support. And as always, like and share is fine, but I'd really prefer any comments, questions, or concerns, then just let me know what y'all are thinking. Thanks so much. Bye.